So by participating or listening to this content, you agree not to use the information presented here as medical advice in treating any medical condition. This forum does not constitute a physician-patient relationship. The content here is for informational and educational purposes only. And because each person is so unique, please consult your healthcare professional for any medical questions or treatment options.
All right, thank you. Dr. Trevino is a licensed and board certified doctor in internal medicine. He received his medical degree from the Autonomous University of Guadalajara in 1982. Dr. Trevino completed his residency at the Albert Einstein College of Medicine in the Bronx, New York, with an associate fellowship in integrative medicine from the University of Arizona Medical School in Tucson. He was Dysautonomia International's Doctor of the Year in 2020. Dr. Trevino, welcome.
Hi, everybody. Thank you so much for attending this podcast. I don't know how many people we have. How many people do we have? From
32.
So we have 32 people from, I guess, all over the place.
Yes.
And just thank you very much for spending your Saturday trying to learn a little bit more about this disorder that is pretty complex and pretty difficult for most of us. Anyways, we have compiled, there was a ton of questions, and there were so many that we had to try to summarize them as best we could. And so we're gonna go on and try to do that for you guys now.
Could everybody mute your microphones, please? And if you do have if we do have you live, if you have to get up, if you would just stop your recording. It's some people have difficulty with a lot of movement, so if you could do those two things, I sure appreciate it. Megan?
Welcome. Thank you so much. Thanks for joining us for our Autonomic Dysfunction question and answer with Dr. Miguel Trevino. So the disclaimer, once more, by participating or listening to this content, you agree not to use the information presented here as medical advice in treating any medical condition. This forum does not constitute a physician-patient relationship. The content here is used for informational and educational purposes only. And because each person is so unique, please consult your healthcare professional for any medical questions or treatment options. So, what happened to my life? Could it be dysautonomia? Dr. T?
So here again, I think the questions that most people who had questions in this area is they are writing about all these symptoms that happen to them, and they just don't know what's causing them because they're so diverse. There's so many of them, but the most common ones are these here: blood pressure dysregulation, my pulse is way up, I have digestive issues, bladder issues, I'm so tired, I have brain fog and fatigue, my bladder's not working, I have temperature dysregulation, I'm passing out all the time. So these were some of the more common themes in general. And I hope we can cover some of them throughout the discussion. We probably won't get to all of them, but we at least will get to some of them. And then at the end, if you have something more specific, you can always let me know, and we'll try to get the answers for you as well. Next slide.
Yep. Froze.
So,
what to do now?
So it takes a long time to get a diagnosis. Most people are really frustrated because they have all these symptoms. Most people who have this disorder are young females. Female ratio to male is 5 to 1. You end up going to the emergency room multiple times. And basically when they examine you, you're in a lying down position, so they can't really diagnose you. They very rarely will do your blood pressure standing for a few minutes to see what happens to your pulse. So it becomes very frustrating for most people. I would say that most times when I see somebody in my office, they come in very skeptical. They come in almost with a sensation of PTSD. I don't want to go to this new doctor that is just going to tell me that there's nothing wrong, that I'm just nervous, that I should just drink some extra fluid and salt and go home, and that I will be fine, because I've tried that, and I've tried that for several years. And a lot of people will get into my office and they'll be just completely frustrated with the system. But I guess the key thing is that you really have to find the right doctor who will be able to listen to you, will be able to take every symptom and everything that you're complaining about and put it all together to make you to help you start getting your life back together. There are some resources that we've put here. The three main ones that we use are the Dysautonomia Support Network, the Autonomic International, and the Dysautonomia Project. There's a lot of good information there. There's tons of slides and videos and all kinds of information that'll help you get your journey to feeling better started. Next slide. And so here the question that we were there was a lot of questions about, I have this, who do I see? I have allergies or rashes, who do I see? I have EDS, and my joints are always subluxing, who do I see? I have all kinds of different conditions, and I don't know who to go to. And so we decided that instead of just answering each one, that we would compile a list of the most frequent complaints, and then who should you see next to them. And I'm not going to go ahead and read all of them, but this list will be there for you so that you can access, and therefore it will help you figure out who to go to. Now, just because a doctor is a rheumatologist doesn't mean that they're going to know anything about EDS, or just because they're a neurologist doesn't mean that they're going to know anything about small fiber neuropathy or Chiari so you really have to try and call ahead, try and figure out, have they treated people with autonomic dysfunction? Do they have any training in the disorders that you may have, whether it be mast cell, autonomic dysfunction, or EDS or hypermobility. So it can be a long journey. You have to find the right people, and that can be very difficult. But just because I would say 90% of the doctors that you've seen don't really understand it and don't know what to do, doesn't mean that you should stop. And so hopefully this will help you get started. So a lot of the questions that we got were, is this life-threatening? Am I going to die from this? Because certainly you feel bad enough that you feel like you're dying. Most people, their fatigue is so severe they can't even get out of bed or lift their head off the pillow. So it can feel like this is a very severe disorder, and yet nobody's really paying attention to you that much. So the key, I guess, answer to this question is that this is not a life-threatening condition. But there are some things that, if you're having all of these simple symptoms, that you want to make sure that you rule out. And so we want to make sure that if you think you have mast cell activation disorder and you have a lot of rashes and inflammatory and allergic issues that nobody has been able to treat or diagnose, we do want to make sure that you don't have mastocytosis, and that may require some blood tests and some other testing as well. The other thing that is pretty important to rule out, especially in patients who have a lot of GI issues, bloating, nausea, intolerance to meals, and to liquids as well, and weight loss, which a lot of times gets missed, is median arcuate ligament syndrome, which causes compression of the celiac artery. So a lot of times you've been to the GI doctor, they've done an ultrasound and a CAT scan, and nobody can figure out why is it that you can't eat. And so a lot of times the answer is especially it's missed because a lot of people who have this are young, and so people don't think that there's an artery being compressed, and sometimes it's very important to make that diagnosis. So that's the second thing. And then the third thing is, if you do have EDS, you want to make sure that you don't have vascular EDS. So a lot of times it is very important to get genetic tested to make sure you don't have the COL3A1 gene. And vascular, genetic testing, fortunately, is pretty simple nowadays. So there was a lot of questions about having dysautonomia as a result of illnesses, surgeries, and life events, and certainly, I've heard it all. I was feeling fine, and then all of a sudden I had a virus, or I had a surgery, or I had a tooth pull. It could be almost anything that triggers this disorder. And then a very common question was also, does autonomic dysautonomia progress? And the answer is that, life progresses, and all the disorders that you may have do progress, mostly slowly. And as the disorders and that you have progressed, sometimes the autonomic dysfunctions that are associated with it as well progress. So in a sense, yes, they do progress, but dysautonomia in itself is not except if you have pure autonomic pure autonomic failure, is not a progressive disorder in itself. The autonomic function can actually improve with a lot of the treatments that we have. And also, if you treat your diseases that are causing it, your underlying diseases, they also can improve as well. So in general, a lot of people are worried I have a disorder that's going to progress and kill me. And in general, no, it's not. In general, most people are going to live, a normal lifespan. They're going to live till their 70s or 80s, but they will have to work very hard for most of their life to manage these conditions. So in that sense, yes, we need to manage it. Yes, we don't have a cure for this. So in that sense, and yes, all the other disorders that are associated with this, with autonomic dysfunction, also can get worse or get worse and better, like the autoimmune disorders, and you're probably going to have to deal with them on and off, at least for the rest of your life. But it's not a disorder that's going to progressively deteriorate and kill you unless you have multiple system atrophy, which is something that we're not going to get into right now, but that's a disorder where there's atrophy of the brain, and it's a degenerative disorder. It's associated with other movement disorders that will kill you in the next 5 years, but that's also very rare. So, there was a lot of questions about that, and I hope that I sort of encompassed all the questions in this one answer. Go ahead. Well, a lot of the people are worried about pure autonomic failure, and do I have pure autonomic failure? Pure autonomic failure is more common in men over the age of 50. It is a very slowly progressive disorder that is very treatable as well, and it progresses over the next 20 years. This is one of the rare conditions that, yes, is associated with progression of disorder, but most people who have autonomic dysfunction, EDS that I see in my office are young people with hypermobility issues or Ehlers-Danlos type issues, and those are the majority. Yes, once in a while we will see somebody who has a progressive autonomic deterioration. Unfortunately, it's very difficult to diagnose because there's no test. We just have to diagnose it clinically. But I would say it's fairly rare, and so we don't really have to worry too much about having pure autonomic failure, unless you're, like I said again, a male over 50 and you're slowly progressing. And that doesn't mean that it can't be treated. It can be treated, and a lot of the symptoms can improve with treatment. But I think what I wanted to kind of say is that even though pure autonomic failure is a slowly progressive disorder that is deteriorating, that also the other disorders, the other comorbid conditions that this is associated with can also progress. And so you have to be able to differentiate both of them. But the fact that you have the other disorders that are progressive doesn't mean that they're causing your progressive autonomic failure or your pure autonomic failure to progress. I hope I explained that fairly well. Now, there was a lot of questions about what to do about different comorbid conditions. And these are a pretty extensive list. I'm sure there's more conditions that are associated with both EDS, autonomic dysfunction, and mast cell activation. These are just some. I think all of them should and have to be addressed separately. And so if you have them, you have to find somebody that will be able to address all these things with you as well. There was a lot of testing. There was a lot of questions about what tests should I get? Are there any other tests that I should have? These are the more common tests that people get when they have autonomic dysfunction. We're not going to get into all of them, but just to say that depending on what your symptoms are, these are a bunch of tests that you may be able to get to help you with your diagnosis and also to help you with the management of your diagnosis. So this is just a list so that you have this as a sort of reference to figure out what tests are you going to need next. These are all the blood tests that are done by Mayo Clinic. Dr. Brent Goodman, this is his list of tests that he orders when he sees autonomic dysfunction patients in his office. So a lot of the questions that were related were I got this test or that test done, and what does it mean, and they were negative, and what is it that Why is it that all these tests come back negative? And so a lot of the problem that we have with testing is, especially, for example, with tilt table testing, a lot of times the person who's doing the tilt table will not know how to look for POTS. They won't be looking at the 40 or 30 beats per minute increase in pulse when you stand up. They won't be looking for even small symptoms as you're standing that make you feel bad. They're just looking for a drop in blood pressure, and they're looking for you to pass out. And so a lot of times people who are doing tilt tables don't know what they're looking for. And if you don't know what you're looking for, sometimes it's very hard to figure out what's wrong. And so it's very important that you try to educate yourself as much as possible about every test that you are going to get done, so that you can look at it and figure out, was this test done correctly, was it done incorrectly, and was it interpreted correctly or not. And so sometimes it's very difficult because a lot of times the tests look normal, but they're not. And a lot of times the tests are normal, and it doesn't mean that you're not ill. For example, with mastocytosis, tryptase levels are mostly always normal. It doesn't mean you don't have mastocytosis. So you have to interpret each test in conjunction with the clinical picture to be able to see to determine its significant or not. And then you also have to realize that a test that I may have here may be different in another country or another state. And so you need to be able to tease those things out as well. People who have autonomic dysfunction can live very normal lives, and normal to them is very different than normal to other person. And this slide was kind of put there because we wanted to say that normal really doesn't exist, and there are a lot of things that you're going to have to put up with when you have autonomic dysfunction that a normal person wouldn't have, but then can be normal for you, and that don't necessarily mean that you have to call 911 and seek an ambulance. Now, there are some instances where it's better to call 911 or an ambulance, but you also have to understand your body. You have to understand what you need to do when your body responds the way it's responding. You have to understand that if it goes away, for example, with POTS, if it goes away when you lay down, and if after 10 or 15 minutes you're feeling back to normal, well, you probably don't need to run to the ER. So what is normal, and what is normal for you, and understanding your own body and what your limits are, and when to call, that's gonna take a little bit of time. It's going to take a little bit of effort. It's going to take a little bit of explanation, but hopefully with time and with your doctor and treatment, you'll be able to figure out when is it that I need to go. I think that the other side of it happens as well, where patients are so sick and tired of going to the emergency room so many times, and they go there and they feel terrible. They're evaluated in the ER. They're told everything's normal, that they can actually stop going to the ER when they feel bad. So it's a double-edged sword. It's better to be safe than sorry. It's better to go to the ER and be told you're okay, go back home, than to not go to the ER when something is bad. So these decisions are tough. Sometimes they need to be made in conjunction with your healthcare provider. And as you get into this disorder and learn more and more about it, you'll be able to make those decisions a little bit better. We put a little slide there about what is within normal limits. And And basically, this is just to say that that just because it's normal on a blood test doesn't mean that it's normal for you or everybody, and it doesn't mean that you're not ill. We can go to the next one. So another question that we got asked a lot of was, what type of POTS do I have? Do I have classic POTS? Do I have hypovolemic POTS? Do I have hyperadrenergic POTS? And what does it mean? And so we just kind of put this slide up just so people could get a little idea of what the different types that are mentioned out there. But in my opinion, it really doesn't matter. If you have neuropathic POTS or hypovolemic POTS or hyperadrenergic POTS, you still have POTS, and it still has to be treated, and you still have to use the medications to treat it. I think one of the things that that does matter, though, is once you get diagnosis, it is important that people understand, are you always hyperadrenergic, for example, because the medications that we use are going to be a little bit different if you're always hyperadrenergic than if you're not, or if you are hypotensive very frequently, medications are going to be different then. But in general, it really doesn't matter what type you have. You're going to have to go by how you're responding, how your blood pressure and pulse are, what medications you can use, which ones you can't use, which ones are more dangerous than others. There are different types, but that's going to be up to your doctor, up to your cardiologist, up to me to try to make those decisions and try to adjust the medication as well as possible. So I get that a lot of people want to know what type of POTS they have, but in general, I don't think it really matters that much, because the management is going to be based on the day-to-day blood pressure, pulse responses, and how you're feeling. This slide, there was a lot of people who had different questions about if I put on, like this question was about coat hanger pain, but there was a lot of questions about different things that people do on a day-to-day basis to help them with their POTS. And in general, what we wanted to convey with the answer for that question is that there's going to be a lot of things that you do on a day-to-day basis that are going to make either your EDS worse, or your POTS worse, or your mast cell worse. And so you're going to have to figure out what those things are. Certainly lifestyle changes, the exercise that you do, how you manage your core strength, your fluid and diet management, your all the things that you do to help you get through a day are going to be very important. And so this is going to be very individualized for everybody, and you just have to work with your doctor on a one-to-one basis to say, okay, when I do this, this is what happens. What does that mean? How can I fix it? And then try to figure out a solution. But certainly there's a lot of things that we can do physically on a day-to-day basis that will help us get through the day a little bit better. We were also going to talk a little bit about muscle relaxers. So muscle relaxers usually do not help coat hanger pain. They can help pain from EDS and muscle spasms, and they can be used, but at the same time, they can make your muscles a lot more flexible, and they can increase your subluxations. So they are a double-edged sword. You have to use them cautiously. So that was a very specific question about muscle relaxers that we felt that had to be answered. So there was a lot of questions about venous access. So a lot of people in their journey of PODS end up getting IV fluids, 1 or 2 liters in the emergency room. And they realize that they feel so much better when they get IV fluids, whether it be normal saline or Ringer's lactate. And because of that, they want to be on IV fluids all the time. And unfortunately, IV fluids are a non-sustainable therapy. So there are people who have to have IV fluids all the time. And there are people who do have IV fluids all the time who have this disorder. But in general, we want to try to stay away from them, from IV fluids, and try to get you better without IV fluids. We had several questions about PICCs and ports and central lines and when to use them. And this slide sort of answers that a little bit. The two main things that are difficult about IV fluids is that, and about fluids in general, is if you're getting IVs all the time, sooner or later you're going to run out of veins. And then the only way to get fluids is going to be through a port or a PICC or a central line. And they all of them have the complication of developing sepsis and blood clots. And when if you get a blood clot, that means you're going to be on medications for several months. If you get sepsis, that means you're going to be on antibiotics for months as well, for weeks at least. And so they have their complications. You can die from the complications of these lines. So in general, most people, the consensus is to try to avoid them as much as we can. We can go to the next one. Oh, questions.
Here we go. If everybody, if you have questions, Dr. Trevino, do you want them to put them in the chat and then Morgan can read them to you?
Sure. Yeah.
Okay. So everybody know how to get to the chat?
Would you like me to take the slides down? Because behind this, we've got just really the disclaimer again. This
Yep.
still did not constitute the physician-patient relationship. You want me to read the whole thing?
Please.
By participating or listening to this content, you agreed not to use the information presented here as medical advice in treating any medical condition. This forum does not constitute a physician-patient relationship. The content here is for informational and educational purposes only, and is because each person is so unique. Please consult your healthcare professional for any medical questions and treatment options. And good old thank you. Goodbye,
Right.
slides.
Thank you, Megan. And we already have a couple questions, so I will let Morgan take over from here.
Okay, so the first question is going to be, how do you help with blood pooling?
So when you have POTS, when you set up or stand up, you have blood pooling, mostly in your legs, upper thighs, and pelvis. And also you have blood pooling when you eat. So when you eat, especially a large meal, all the blood goes to your intestines and pools there. So the worst thing you can do is eat a large meal standing up, because then you'd be pooling in your upper thighs and pelvis and pooling in your intestines. So we deal with pooling by wearing compression and by eating small amounts throughout the day. This eating small amounts throughout the day not only helps with the compression, but with the pooling, but it also helps if you have gastroparesis and gastric dysmotility, which is very frequent, very common with autonomic dysfunction. Now, as far as what kind of compression do you use? Well, basically, it depends, right? So if you live in Alaska, you can wear the really thick compressive garments and be very comfortable because it's cold there. But if you live in Florida, it's very difficult to wear the compression. So a lot of compression garments because they're hot, and with heat is very intolerable to most people who have autonomic dysfunction. So you do the best you can. We recommend Spanx, bicycle shorts, leggings. You have the sports leggings that you can wear. You're just going to have to try as many things as you can to help you with compression. You should put them on first thing in the morning. You can take them off at night. You don't need them when you're sleeping. And then for the intestinal pooling, abdominal binders can help some people, especially after meals. They don't help everybody. A lot of people get a lot of bloating after meals, and so they can't tolerate anything compressing their abdomen. So sometimes it's difficult. Basically, you just got to do the best you can.
Dr. Trevino, are there any medications that are used to help control the pooling for people that, have difficulty with the garments, with the, compression garments?
Midodrine is a peripheral vasoconstrictor. So, I mean, that can help a little bit with the pooling. So peripheral vasoconstrictors may be able to help a little bit. But no, I don't know of a lot of medications that we can use to stop the pooling. Anyways, it doesn't stop. Do you guys know of any?
Not necessarily for blood pooling, but maybe like Northera to increase the circulation.
So yeah, I find that people who have a lot of abdominal pooling, especially people who drop their blood pressure, whether they drop it when they stand or they drop it after eating, which is from the abdominal pooling, Northera seems to be the one that helps the most with it. So that's also a peripheral vasoconstrictor. So midodrine and Northera can help a little bit.
Not a med, but vibration plates can really help play with this because of how it works with the nitric oxide and natural way to come at it, more on a, I'm having this symptom now moment.
Okay, so the next question is, sorry, go ahead, Dr. T.
Go ahead.
So this patient had a sympathectomy. Do you think that could have worsened temperature control or have any relation to dysautonomia?
So in general, when you have a sympathectomy, then you can have your parasympathetic side of you kind of takes over. So it's not uncommon. It's pretty rare, but it's not uncommon. It depends on how extensive the sympathectomy is, but it's not uncommon for a patient with a sympathectomy to have some symptoms of the parasympathetic side get worse. And just depending on what they are, you can try to deal with them. But yes, sympathectomy can make things worse, but then you have to kind of weigh that towards the benefit from the sympathectomy. So sometimes it's a tough decision.
Okay, and what are your thoughts about using vagus nerve stimulation to improve function of the autonomic nervous system?
So in very few trials, vagus nerve stimulation has been shown to be, for some people, beneficial. And they have several types of units that you can use for those. I think there needs to be more research to really figure out how it works. I'm not sure that, I want to turn this off. I don't know how. I got it. What was the question again?
About the vagus nerve stimulation.
Oh yeah, so I think it can help some people. Not sure how it exactly works and why it doesn't work on everybody. But I think it's worth a try. So if you have good benefit from it, just keep doing it. But I don't know that it works for everybody, and I think more research is needed for that.
Okay, and then I have nights when I sweat all night and wake up feeling very rough, like I'm stuck in fight or flight. Could this be related to dysautonomia?
Sure. So a lot of people, especially people who have a lot of adrenaline or have too much adrenaline in their system, can have issues with waking up, feeling shaky, jittery, sweating, and then all that can be part of autonomic nervous system dysfunction. There are some things that you can try to do with that, but it's a very difficult situation.
Okay, and next question is, do you have any tips to help communicate to doctors, and how do we respond best to get testing?
Do I have any tips to tell people how to respond to doctors?
Yeah, or I think they're pretty much asking like how to communicate with a doctor, and how to really like advocate for the testing.
Yeah, I mean, I guess the better educated you are, the more you'll be able to advocate for yourself and the testing. I find that most people that I see are as educated or more educated than I am as far as all the autonomic things and variants and contingencies that can happen, both with EDS and autonomic dysfunction and sometimes mast cell activation. Just a lot of people have a lot of knowledge about this, and when you go to the doctor and the doctor doesn't know anything about this, it can be very difficult. So you just got to be gentle, be kind, be persistent, ask over and over again, is this a possibility? Can you can also say, just for my peace of mind, can we order a tryptase level, or can we get a tilt table test? I just want peace of mind. And then most of the time they'll say, unless they have to pay for it, which a lot of insurance systems nowadays, everything that the patient does comes out of the doctor's pocket, and so they will say no. But most of the time, if you say, I know this may not mean a lot, but I just for my peace of mind, can I have this done or that done? And most doctors, I think, will say, sure, even though they think it's not indicated.
Dr. Trevino, one of the things that you taught me early on when I came to you, I have had illness for 40 years, and I came in with 3 pages of symptoms and diagnoses and all of this. And he taught me that overwhelms the doctor. Pick your top 3, focus on what the specialist is, base your questions on that. So that really helped me to find better doctors to care for me by not overwhelming them with my 40 years of illnesses.
Yeah, it's very difficult for a doctor who in this system, who has 15 minutes to see you for a complete physical and exam, for a complete evaluation with an exam, which is what most patients get for a complete exam. And maybe you'll get half an hour. Even half an hour is just very little time to try to go through 3 or 4 pages of all these symptoms, which are basically almost every organ can be involved. And so focusing on small things, focusing on what's your worst symptom makes a lot of sense. Yeah.
Okay, and then how do you help with hydration with the body? Like if my hair, eyes, and body just feel very dry.
So, well, there's we always recommend extra water and salt for everybody who has POTS. But having said that, a lot of people who have autonomic dysfunction have other issues with dryness, dry eyes, dry mouth. You can have an autoimmune disorder like Sjogren's, which causes dry eyes and dry mouth. So depending on what like for dry eyes and dry mouth, natural tears, there's artificial saliva that you can use, moisturizers for your skin, as long as you don't react to them if you have mast cell activation, and just doing the best you can with your hydration. Most people who have this disorder have to if they're walking around with a bottle of water with salt and electrolytes in it, and they're just taking sips throughout the day, that's what you have to do.
Okay, and then can I go to my neurologist to be diagnosed with POTS instead of a electrophysiologist?
So then a neurologist who is trained in autonomic nervous dysfunction should be able to do a poor man's tilt table and diagnose your POTS. Whether that will happen or not, I don't know. Traditionally, an electrophysiologist and EP cardiologist are the ones who are in charge of doing tilt table testing, and those are the ones that are going to be a little bit more familiar with how to interpret tilt table testing. So I think the answer is both should be able to diagnose it. I think the main thing is to be able to get the right person who knows what to look for when you're doing the tilt table test.
Okay, and then are there medications besides beta blockers that can help with tachycardia?
So the medications that slow your heart rate down are beta blockers, alpha agonists like clonidine and guanfacine, and then we have Corlinor, which is a drug that we use for heart failure that also slows your heart rate down. There's other things that you can use. Midodrine slows your heart rate down. Mestinon can slow your heart rate down. So there's a few medications that you can use, and you can use them together to get that pulse down. I think in general, my goal when I treat people is to get their heart rates down to maybe 60 when they're laying down and 80 or 90 when they're up and around.
Okay. To build off that, I actually have my own question. Is there like a bradycardic heart rate where you would say that's too low?
Yeah, so if your heart rate is going too low, so you have to correlate that with your symptoms. So if your heart rate is 50 and you feel terrible, well, then that's too low. But somebody, like an athlete can have a heart rate of 40 or 35 and feel fine. And so then that's not too low. So it just, you have to look at case by case. If you're bradycardic and you're feeling bad, yes, it's too low. You're going to have to back off on some of the medications. If your heart rate is certainly below 30 or even 40, that's a warning sign. I would want to make sure that you don't have anything else going on that's causing that.
Okay. All right. So this next one, I'm going to summarize a little bit. My biggest trigger for pain and severe dysautonomia reactions is sugar intake. I had a reaction to IV fluids with dextrose where I went into severe sweating and fainting, nausea and vomiting, and no one can explain why this happens. Do you have any thoughts on the reaction to the sugar intake?
What I would, if you have a reaction to anything, I would want to make sure that that it's not a mast cell reaction, and it's not only a reaction to the sugar, but what the sugar came with. So did it have glucose? Did it have?
It just says sugar intake like IV fluids with dextrose, and it also happens orally and through fluids.
I believe I spoke with this person and she did say that she is completely sugar-free.
Yeah, I don't know why what kind of reaction are they having?
Severe sweating, fainting, nausea, vomiting.
Does their blood pressure drop when they take sugar?
Trisha? Let's see.
Trisha, are you on?
Sugar-free and severe sweating, pain, and body buzzing.
Yeah,
So-
I would say that it's like all the time. Anytime I have a reaction, it's when I can take in any kind of sugar. It can be a real sugar, a fake sugar, a fruit sugar, or even like I said with the dextrose in the IV fluids, it was when I stood up. So like as I was getting the fluids the whole time I was getting them, I was fine. But the minute that I stood up, it was like I had a full-blown dysautonomia flare. My body was buzzing and I couldn't see straight and I was dizzy and had nausea and throwing up.
Do you know if your blood pressure and pulse went down?
My pulse was high. I didn't check my blood pressure, but yeah, my heart was just like pounding through my chest, super high.
So if your blood pressure went down after the sugar, I would worry about a mast cell reaction causing it.
Okay.
So
And I do have mast cell, and I'm on a bunch of medications for mast cell, and that does help my instant reaction to sugar. But I would say I still can't take in sugar even on all the mast cell reactions. So it's interesting that you think that it's still a mast cell reaction. So thank you.
Okay, the next question is, how can I be sure I don't have mastocytosis? I have a lot of pain on my abdomen and in my joints, especially after eating.
So mastocytosis is a disorder that is ruled out if all your tryptase levels are normal, and let's say you get the 24-hour urine histamine and other marker testing, and that's all normal, and you're still having a lot of mast cell symptoms with a lot of allergic inflammatory reactions, then you probably have mast cell activation. So you would have to get the blood test. Now, if your blood tests are positive, if you have high levels of, for example, tryptase, then you need a complete workup for mastocytosis to rule it out. And that may include a bone marrow biopsy and genetic testing that you may have to have. So to rule out mastocytosis, it takes a little bit of doing. You would probably have to see a mast cell specialist or be part of a research study where they'll do all those tests. And then what was the next part of the question?
It was pretty much just how to assess if you have mastocytosis or not.
Yeah, so to diagnose mastocytosis, you first would have to have elevated markers, and then if you have elevated tryptase and other markers, then you would proceed to get genetic testing in a bone marrow.
Okay, and then how do you help with the feeling of weakness and fatigue in your arms and legs despite normal strength?
Well, I mean, I think that's a pretty common complaint with all these disorders, both mast cell, the autonomic dysfunction, PODS. All of these disorders cause significant fatigue. If it's a muscular thing, I think sometimes methadone helps people, and methadone also helps lower your pulse and blood pressure. And sometimes people feel a little bit stronger with that. So you can try it. But in general, you have to use medications that increase blood flow to your brain, like midodrine and Northera, and also stimulants also can help, which also raise blood pressure, increase blood flow to your brain, as well as give you more energy. So most of the time, we have to use some sort of stimulants, whether it's midodrine, Northera, or other type of stimulants.
Okay, and then I'm not quite sure what the question is, but they're asking about myelopathy with autonomic dysfunction.
So what do they mean by myelopathy? Do you know?
Pretty much saying myelopathy of the spine. They won't do surgery with the autonomic dysfunction.
I don't know what that would mean as far as you have some sort of spinal cord disorder. I'm not sure.
Is that causing all of it?
Certainly could be contributing to a lot of it, yes.
Because it started with like brain crawl sensations. They thought I was having allergic reactions to medications. The brain crawls are still there, severe brain fog. My feet were numb for 3 years. Now they've hurt for 3 years. It's climbed up to my knees. My pulse is standing at about 150, laying down, it's 110. I had surgery on my spine, emergency surgery on my L4 because I couldn't use the restroom. They said, go to ER. They kept me there with fluids for 5 days. Finally did the surgery. My pulse dropped to 30, stayed there for 3-4 days. And I've been waiting to see a specialist in this area for a year now. I live in Utah and I still haven't seen one.
Yeah, I mean, with the amount of information that you gave me, it's hard for me to tell you what's going on. Certainly all those symptoms can be caused by several types of neuropathy. Small fiber neuropathy, autonomic dysfunction can cause a lot of the symptoms that you have in itself. So, but if on top of that you have issues where you're having compression of your spinal canal, or nerves coming out of it, can cause all problems like that as well. So just from the information that you're giving me, I just really not able to pinpoint what's going on.
I've been told I have everything you just said by the Mayo Clinic, but I ran out of money, so they ran me out of town.
Yeah.
Could
Well,
it be the spine?
They have a good place up in Utah. Doesn't there's a new center opening up there.
What's it called?
Paces?
Salt Lake City. What?
Is that Laura Pace's group?
Yeah, Laura Pace's group.
Brian, I'll send you the link to the company.
Thank you so much.
You're welcome.
Okay. I'm just starting this journey. I have so many normal symptoms, but I'm hearing about so many other things I didn't realize were possible. Is there some kind of list of symptoms to be looking for?
So we provided in the slides a few lists of symptoms associated with what tests we use. I'm not sure what specifically you're looking for to be able to recommend the test.
Okay. And then Trisha was having the sugar issues, and she's just clarifying. So if her blood pressure drops, it would likely be mast cell. But what would you think if her blood pressure increases?
So if her blood pressure increases, that could be an adrenaline response that's causing the issue. And then I would want to find out why is there an adrenaline response to taking in sugar? What's triggering that? I'm not sure.
Okay, so I've had all kinds of testing and no one can really figure out why I have abdominal pain and joint pain, especially after eating. Do you think mast cell would be something to pursue, or if she should look elsewhere?
Yes, I think any time you have a inflammatory or allergic kind of condition that nobody can figure out, that's consistently inconsistent, where everybody looks and they can't find anything wrong, that it is worth looking into mast cell.
A lot of my dysautonomia symptoms have progressed into the neurological field. I've begun losing my speech when I get sick. Is that dysautonomia related?
So that could be from brain fog. That could be dysautonomia related. I'm not sure that it is, but certainly what we think that when people sit up or stand up, there's a decrease in the amount of blood flow to the brain, which can cause a lot of those neurologic type symptoms. So yes, it is possible.
Okay. All right, and that is all questions from the chat box. Does anybody else have any questions?
That's amazing. There were 47 chats, so that's good that you were able to condense all of that.
And Cindy, everybody well, not everybody, but a few people are asking if you're able to post that link for the Utah group.
Yes, I will post it in the main group. It's the lady from Facebook that was diagnosed with POTS, who is now the CEO of Instacart, her and Dr. Laura Pace, who's very well known in the dysautonomia international world, and one other doctor have started this dysautonomia clinic. So I will post it in the main page.
All right, and we just got another one. Uh-oh. Okay. All right. If I have too much adrenaline, what can be done about that? Would it be part of a psychological issue?
If you have too much adrenaline, what can be done about it?
Yes.
So a lot of people get diagnosed with anxiety when they have too much adrenaline because they feel shaky and jittery, and then they go to the doctor and they say, I feel shaky and jittery inside. Sometimes I wake up in the middle of the night feeling shaky and jittery, and they get diagnosed with general anxiety disorder. So it's very frequently misdiagnosed as an anxiety disorder, having too much adrenaline. Most people who have anxiety will have anxiety because of something, or because they're going through something, or there's a reason for their anxiety. And people who have too much adrenaline, they just feel shaky and jittery and they don't even know why. Or if you wake up in the middle of the night from sleep and you're shaky and jittery, it's probably not anxiety, it's probably something else. And so, yeah, there's a lot of the medications you can use. The medications that we usually use to try to combat the adrenaline are alpha agonists and beta blockers.
My daughter has ongoing nausea. What could be some background causes? And do you know of any particularly helpful medications for that?
My daughter has what?
Nausea.
Nausea. So nausea, bloating, abdominal distension, the intolerance to large meals are all pretty common symptoms for gastroparesis, but you can have other things causing it. So I would say if she has all those symptoms, that she needs a workup, maybe see a GI doctor, but that knows autonomic dysfunction. But there's multiple medications that you can use for nausea. I think the most common one is under the tongue Zofran. Works very well for a lot of people, but there are others if that one doesn't work as well.
Okay. And then do you know if pseudo seizures are linked to dysautonomia?
So yeah, so what happens to a lot of people is they get these seizures that, I've had multiple people even film them for me. And they certainly, when I look at the videos of them, I say, that is certainly a seizure. It looks like a seizure to me. But when they go to the neurologist and have a complete workup with all the EG testing, they determine that they do not have seizures, that they have pseudo seizures. And that's part of the autonomic dysfunction with, I think what causes it is decreased blood flow to the brain. And so the treatment would be to try to get more blood up there by using all the things that we use to treat POTS.
I walk 6 to 8 miles a day to combat my adrenaline, and I feel like I'm in fight or flight. I would love to know if there's a medication that could help.
So when you exercise in an upright position, you trigger that whole adrenaline response. But what may work better for you is exercising in the laying down position, like swimming, recumbent bicycling, or rowing. And then the two medications that will help you with the adrenaline response are beta blockers and alpha agonists. Alpha agonists are clonidine and guanfacine. Those are the ones. There's another one, but I forget the name. I don't really use it much.
Okay. Do you find that people with low stomach acid or a microbiome issue from extreme antibiotics, do you have any advice on building that back up, or are there any risks with taking H1, H2 blockers?
So I don't think there's a lot of risk taking H1, H2 blockers. Yes, you are decreasing the acid in your stomach when you take H2 blockers. But at the same time, if you have mast cell activation, and that's causing most of your symptoms, and you take H2 blockers and it helps you, then I would say that you'd have to weigh the treatment of having less acid in your stomach, the bad parts of those towards, weigh it against having mast cells under better control and having less symptoms. If that's working for you, then you have to make a decision. But I would say it's more important to treat your mast cells at that point. Because when you have a mast cell activation disorder, most people have too much gastric acid anyways. That's one of the symptoms of having a mast cell activation, is having too much gastric acid. So I think the H2 blockers can help in both of those ways.
And then last one, I have an elephant on my upper chest and back. Sorry, it just got moved. Okay, I have an elephant on my upper back and upper chest, but when I'm in a pool, I almost feel normal. Is there any medication to help with that?
So
Like chest pressure?
do you think it's the compression of the water that makes you feel better? I don't know. I don't know what an elephant on your upper back and chest means. What is that? I don't know what that means. Is it pain? Is it pressure?
Heavy pressure.
Is it day and night?
Yes.
So it sounds like when you're out of the water, just gravity is making you something in your musculoskeletal system is off and causing you to feel that pressure. And when you get in the pool, that gets relieved because, of course, now you're not fighting gravity anymore. And so I would look to see what is it in that area of your chest that could be causing that problem.
Okay, can dysautonomia be caused by genetic mutations?
So yeah, there are familial autonomic dysfunction dysautonomias that are genetically transmitted. Yes, they're pretty rare, but yes, they.
Is constant thick mucus in the sinuses despite surgery, steroids, and 6 weeks of antibiotics a sign of mast cell?
Can you repeat that again?
So constant thick mucus in their sinuses despite surgery, steroids, and 6 weeks of antibiotics. Do you think that could be from mast cell?
It could be.
And can mast cell cause destruction of collagen in the skin?
I don't know what that means, so I wouldn't know. Okay, that's it for right now.
All right. Dr. Trevino, thank you so much
Oh, thank you all for
taking almost 2 hours of your time.
For listening and for trying to learn more about this disorder, which is very tough.
We will be, as you know, we're recording. We have a member that volunteers that will edit it and we'll upload it to YouTube. And when we do that, I'll make sure and post it in the group so everybody has access to the recording. So Megan, go ahead. You're going to read the disclaimer one more time.
By participating or listening to this content, you agree to not use the information presented here as medical advice in treating any medical condition. This forum does not constitute a physician-patient relationship The content here is for informational and educational purposes only. And because each person is so unique, please consult your healthcare professional for any medical questions or treatment options. Thank you everyone so much for being here and for submitting your questions to us.
And I want to thank everybody who does this for us. Megan, Morgan, Cindy, thank you so much for doing all this really, really hard work. It took a lot of work. Thank you so much.
Thanks, everybody. Have a great Saturday afternoon.
All right, bye.
Thank you.